Sir, you have diabetes control panina. After that, sir, if diabetes control, you will not be standing here, sir. That's the first thing. So let me take you to this topic. Thank you, Kumaril sir. Aruna, thank you so much for the invitation and nice talks. And Raghuram sir and Arun. And thank you, team receptors. So I start my talk with a quiz question. There is a different question. The question has changed now. Syllabus married. What is this? So again, as usual, I'll give a chocolate for somebody who could give an answer for that. Sir? Perfect. Slide that's called as bar flower kadamvanam. So that brings us, I bring greetings from the temple city. Pranams to my teachers, which includes our Moses sir. Sir, avaru ungalku paina na ungalku enna? Anand Kumar ungalku son, naanga engalku enna sir? So let me start this with the first question, the quiz question for you all. Name the commonest diabetic neuropathy. Anybody? The commonest neuropathy. DPN, this distal symmetric peripheral neuropathy. Give a chocolate to sir. Please come. So that is a common one. So commonly when we divide diabetic neuropathies, there is a peripheral neuropathy and autonomic neuropathy. We also distinctly divide this proximal neuropathy and the focal neuropathies, which could be entrapment syndromes, cranial neuropathies, and truncal neuropathies is torso and leg separate neuropathies. So diabetic neuropathy, when we say unqualified, we mean only the distal symmetric peripheral polyneuropathy, which is a painful neuropathy. And by definition in this talk that is excluded. It's apparent in 30% of people with diabetics, more common in type 2 than type 1. In type 1 it's quite simple. Higher the glycemic levels for a longer duration, you get this neuropathy. Whereas it's not so simple in type 2 diabetic neuropathy. In addition to glycemic levels, there are additional factors, importantly the metabolic control that plays an important part. So quiz question for the audience next. Which of the following is not part of the metabolic syndrome? A, B, C, D. Loud sound to get the chocolate. Which one is not part of metabolic syndrome? Sir? C. Perfect. Who said C? Perfect. The answer is C for this. When you look at a metabolic syndrome, it includes so many things which is mentioned. In addition, hypertension and obesity, they form the pentad. LDL elevation is a risk for cardiovascular complications, but it's not listed as a part of metabolic syndrome. The message I'm giving you is that prevention is the key. You get the diabetes under control, keep the metabolic parameters under control. That's the only way you can prevent it, and prevention is the most important aspect of getting things right in terms of diabetic neuropathy. But let's say a patient gets into diabetic neuropathy, can we do something about it? So that is a question for you all. When you have a diabetic neuropathy, which one of the following about the progression is correct? When you have intensive therapy, it slows the progression of both peripheral neuropathy and autonomic neuropathy. It does none. It does one but not the other. Choose the answer from this ABCD. That's relevant to us. C. C. Who said C? So I'm going to give you a chocolate. I'll give you an answer for this. This is from the Steno 2 trial. The multifactorial intensive treatment trial was a standard therapy, behavioral therapy, and all the things were taken care of to keep the diabetes under control. And so many pharmacological interventions were also part of the trial. When you look at that, this is the largest data for this. The equipoise is touched only by the peripheral neuropathy. You get good benefits in terms of nephropathy, retinopathy, autonomic neuropathy. So I'll skip this, but the point I'm trying to tell is that when you have a good diabetes control, autonomic neuropathy can be prevented from progression. The routine peripheral neuropathy will continue to progress. You can only achieve pain reduction. You will not be able to arrest the progression of the neuropathy. Now the point is that the question is that even if autonomic neuropathy has set in, you can prevent progression. The routine peripheral neuropathy will progress. How does it make sense to us? How does it become relevant to us? The relevance is that peripheral neuropathy is a nuisance, pain, all those things. But autonomic neuropathy is a killer. So let us focus on something which is preventable. What is preventable is autonomic neuropathy, and that's the reason why I put up that slide. A 54-year-old gentleman with no previous comorbidities undergoes mastocytal checkup for peripheral paresthesia. The involvement was symmetrical and followed a stalking pattern. His sugar was 254 fasting, 424 postprandial, HbA1c was 8.4%. So he was diagnosed with a diabetic neuropathy and referred for opinion. What is your approach here in this patient? What are the drugs you will give? What else you will do for this patient? Any quick glance at this? The point is here, distal symmetric peripheral polyneuropathy pattern is a duration dependent pattern. You do not get this neuropathy at the onset of diabetes. Rarely only you will get, if a person has got impart fasting glucose for long, IGT can sometimes produce this pattern, but by and large common things are common. This peripheral neuropathy needs separate evaluation. That's what we did for this patient. He had nerve biopsy proved vasculitic neuropathy and required immunomodulatory therapy. Always remember, diabetes and hypertension are common diseases in the society. We always need to look for etiologies beyond, and pattern recognition is the key. So this is a 50-year-old lady with 6-year history of diabetes. She came with neck pain and giddiness. So what is the common test that is done? When a person comes with neck pain and giddiness, when you see in practice, nowadays we are now advanced to going to MRI. Any other test we do it. Absolutely useless test. At least MRI is fine. What is that, sir? Doppler. Then? Cervical spine X-ray. Absolutely useless test. They show no purpose, and there is a mythological understanding about the cervical Doppler giving any contributory there. Nevertheless, we'll have a discussion of this separately. And this patient was given collar. No use. Absolutely no relief. In fact, the patient became worse. And physiotherapy was advocated and patient became much worse. Our teachers teach us that the most important part of treating a person is to take a history. Dr. Kasiran sir used to tell us his story he will teach us. So history is the most important part. Any clue on this patient diagnosis? Cervical MRI and all those things absolutely non-contributory. Just some degenerative changes and nothing else. Any guess on this diagnosis? If you look at that carefully on that picture, something is drawn on that picture. That gives a clue. Coat hanger, sir, chocolate to sir. That is coat hanger therapy. The thing is that the patient's history was that the patient got severely worse on standing up. And the moment she lied down, she became better. And there was a retrocolic here. This is a very common complaint with poorly controlled diabetics. That's called as a coat hanger phenomenon. The reason why this happens is because the pain is in the coat hanger phenomenon because the muscles, the tonically active muscles to keep your neck erect are your spine muscles there. And those muscles have to be perfused well. And that perfusion becomes low in erect position because of the same postural hypotension like phenomenon, and they cannot keep it upright, and they become much better upon lying down. And always a careful history tells you a diagnosis, and then the treatment has to be guided by that aspect alone. This is a 72-year-old gentleman, diabetic since 16 years, presented with tingling paresthesia over lower limbs and consequent sleep disturbances, went to a practitioner. He was on a medication elsewhere, all of our own cases. Presented 3 days later to the emergency with agitation and restlessness. Clinical examination at this point of time, heart rate 140, blood pressure 140/90, temperature elevated, dry mouth, dry skin, pupils appeared dilated, no papilledema, urinary retention requiring Foley's catheter. This is a diagnosis of acute confusional state / organic brain syndrome is made. What's the most likely diagnosis here? A, B, C, D. Which drug? Perfect. It is a tricyclic antidepressant related. This is a very common scenario, you can get it. The reason is because if you look at our sympathetic and parasympathetic system, the preganglionic, all of them are acetylcholinergic. The postganglionic changes. You have acetylcholinergic postganglionic output at some levels, and to the sweat glands, this is noradrenergic output. In these two levels, when they are blocked, the abnormalities will be, and all these things are which type of receptors? One more chocolate to that. Which type of acetylcholinergic receptors you are talking about? There are two types of receptors. These are muscarinic receptors. All of them are muscarinic receptors. You have the nicotinic receptors, the preganglionic segment. All of them are muscarinic receptors. So you have impaired parasympathetic control, resulting in tachycardia to the heart, tachycardia, and then to the pupils producing mydriasis, dry mouth because of salivary gland involvement and urinary retention, sweat glands, that is why you get the dry skin, and acetylcholine is important for processing your brain. In fact, Alzheimer's disease, what's the treatment we give? Cholinergic medications. So attention impairment, sensory processing impairment, All of them were involvement of the muscarinic receptors, and the drug was perfect. We give chocolate to madam, it was amitriptyline. That was amitriptyline. Patient was prescribed 25 mg of amitriptyline and came with this phenomenon. Let me move on to this 48-year-old gentleman, 5-year history of poorly controlled diabetes. He presented I presented this with Dr. Kumaran sir and in one of the previous meetings, presented to the family physician with history of passing white-colored urine, milk-like urine. He was diagnosed with candidiasis, poorly controlled diabetic. And what's the treatment for this? Sir knows his case. What's the treatment for this candidiasis we give commonly? Fluconazole. The patient was given fluconazole. He did not improve. He was suggested to take cranberry, did not get better, and went to the urologist who did 2 advanced tests and then gave a diagnosis. What are those 2 advanced tests which gave the diagnosis here? Anybody from the audience except Kumaran sir? He knows the case. What are the advanced tests he did, you think? Madam? Absolutely. And what did it show? He did advance in the form of history and did a urine analysis. Chyle. Anything else? It was not chyle. Perfect. Semen. Who's at semen? Put up your hand. That's perfect. So it was a dry climax which came up for history and postcoital cavity urine, and this was semen in urine, and that gives, please give it to BRJ also. It's semen in urine. So the point is that always ask for genitourinary dysfunction in patients with diabetes. Always ask for sexual problems because they hardly come and volunteer and tell you about this. But it is crucial because it is an indicator of autonomic neuropathy. Small adjustments like withdrawing beta blockers might help. This is an interesting patient. Again, sir knows this case. 46-year-old IT executive. 5-year history of poorly controlled diabetes and hypertension. You look at the number of drugs patient is on. You can just read this, self-reading. And then this patient had erectile dysfunction. So when he went to the practitioner, he was told, this is the price you pay for poor diabetic control. What do you expect? This is one of the reasons why non-modern medicine practitioners are more popular than us. And this is one example. So he said, can I use Viagra? I said, no, you'll get cardiac arrest. And that's the reason why a patient did not take Viagra. BRJ will clarify, will Viagra produce cardiac arrest, but he can tell this. But he said, do you want side effects? So he consulted Dr. Google. This was the day before this ChatGPT came to us. Now it is Dr. ChatGPT, but before Dr. Google, he said, Yohimbine is a medication which has been used for all this erectile dysfunction. We know that Viagra has side effects because we are practicing it, but herbal remedies, they don't have any side effects. That's one of the dictums we have practiced, in the practice we always come across. There's no side effects. So this patient ordered it on Google, on Amazon, and took this medication. And guess what, how he came to us? He came with severe hypertensive crisis. So let me just explain to you what happened in this patient. We subsequently sat with the emergency residents and looked into this data, what happened. When you have diabetic neuropathy, you have erectile dysfunction, and then the patient is on beta blocker and a thiazide diuretic. So erectile dysfunction was a real problem here. And then this patient is on amitriptyline. Amitriptyline is known to block the neuronal reuptake of norepinephrine. So norepinephrine levels are higher in this patient. Yohimbine is known to release norepinephrine from the sympathetic nerves. So the combination increases the norepinephrine delivery to its receptors. And then look what happened here. You got a diabetic autonomic neuropathy. You have a barrel reflex which curtails your hypertension crisis, and that is affected in patients who have got diabetic neuropathy. And there is a barrel reflex failure. The norepinephrine induced increase of hypertension goes unchecked, and this patient comes with paroxysmal, potentially lethal hypertension. He required intravenous medications for control of hypertension, and then we need to counsel them. Very important to counsel patients about over-the-counter medications. 60-year-old lady, she came with painful polyneuropathy with severe ataxia. She had been diagnosed with diabetes mellitus 8 years ago, initially treated with metformin, and 2 years later glimepiride added. Good control of diabetes, always sugar, HbA1c less than 6.8%, and a vasculitic screen and a malignancy screen all were negative. But a simple lab test gave a diagnosis. What is this test and what is the diagnosis here?
Peripheral smear.
Peripheral smear gave the diagnosis. Cirque chocolate, Dunkin' chocolate. This is metformin related B12 deficiency because of impaired terminal ileal absorption. This is by altering the calcium dependent binding of B12 intrinsic factor complex. The prevalence of B12 deficiency in metformin use can raise up to even 30%. The neuropathy develops insidiously and mimics diabetic neuropathy, and that's the reason why it is often missed. The risk factors are metformin dose more than 2 grams, intake more than 5 years, pure vegetarian diet, and age more than 60. Now if there are postgraduates, I will ask this question. This is the differentiating point. What is the differentiation? We said it is a neuropathy, it is a neuropathy and not a post-column. What is the clue here for B12? More than a neuropathy. I gave away the answer, it is posterior column dysfunction. When you have an additional posterior column dysfunction, you know that this is not actually a neuropathy, it's actually a spinal cord involvement. So how do you clinically make it out? Are there postgraduates here? MD postgraduates? Always a tough question for us, for practitioners. Now when you check the vibration sense and the joint position sense in practice, more often than not, joint position sense is earlier abnormal in patients with neuropathy. A vibration sense is more often abnormal in a patient who got a posterior column dysfunction when they have ataxia. And then we also look for length-dependent pattern. In a cord involvement, the length-dependent pattern of involvement does not occur, whereas in a neuropathy, often in axonal neuropathy, you have a length-dependent pattern. Additional rhomboidism, the dorsal column signs which I mentioned, the tongue signs, vegetarian diet, and macrocytic anemia are the clues which tell you that it is not a diabetic neuropathy, it is B12 deficiency related neuropathy. A 52-year-old lady underwent a mast cell checkup. HbA1c done in terms of untreated diabetes of 1 year duration was 14.6. She never took the medication. Insulin was administered to achieve tight diabetic control. 6 weeks later, she came with painful paresthesia, burning feet. HbA1c had improved significantly, and she told the doctor, all because of your medications I got this. So she was referred initially to neurology and then to the psychiatry, anxiety neurosis. On examination, she had ankle areflexia and hypoesthesia to pain over the feet. Motor examination normal. What is the best option now? Will you continue insulin in the same aggressive fashion? Will you reduce insulin and opt for less aggressive diabetic control? You will stop insulin and switch to oral hypoglycemics, or you refer to a psychiatrist. What will you do in this patient? A, B, C, D. B. And why do you say B? Why B? So the diagnosis is perfect. This is treatment-induced diabetes. But the answer to this choice is not correct. The answer is continue insulin in the same doses. Why? The reason is because before that, how much reduction in HbA1c is acceptable in 3 months? This is a question not to ask in this forum. You will all know this, so I will not wait for the answer. The recommended is 3%. If the reduction is more than, the risk is 10% if it falls more than 3, and 50% if it falls more than 5%. The point why I gave that answer, I have not put it in the slide. Once the neuropathy sets in, it is irreversible. You can do nothing about it. So there is no fun in trying to reduce your insulin and risk further neuropathies. The good thing is that it is a self-reversible phenomenon. No matter how much pain the patient reports, within another 3 months, the paresthesia will completely disappear. By opting for less intensive control, you will not be able to give benefit to the patient, and that's the reason why you don't have to reduce the insulin dose. Stay with the good control. In addition to that, beyond pain, look at so many things. The color, the texture, the edema, nail changes, ulcer, healing issues. All these things are important when you manage a patient with diabetic neuropathy. Otherwise, devastating complications could happen. Clinical question. How do you clinically evaluate for peripheral vasomotor function at the bedside? How do you say that? Vasomotor function is affected. How do you say that in the bedside? Anybody? Any clinical test. This is our own clinical test, their own patient. If you look at that, now here on this is the patient, this is the daughter and this is the patient, and ask them to put it into a glass of water, and you look at that. At the end of it, you ask them to show the hand. I'll run the video quickly, and you can see that there are wrinkles in a normal person. The absence of wrinkling is a sign of peripheral vasomotor dysfunction in patients with diabetes. So the clinical bedside evaluation is look at the wrinkling after several minutes of immersing your hand in water, which is a function of sympathetic noradrenergic failure, which leads to this phenomenon. So to summarize, diabetic autonomic neuropathy is a killer, but fortunately it is preventable. A routine peripheral neuropathy is usually not a killer unless you develop these changes, but it is irreversible. Neck pain is not automatically equivalent to cervical spondylosis, especially in a diabetic. Always remember autonomic neuropathy and the cotangular phenomenon. Sexual functions are very important to ask. It should always be discussed with the family, otherwise they will be going to the wrong doctor. Beware of treatment-induced diabetes, try to prevent it. Once you get into trouble, do not take your pedal off the accelerator. B12 deficiency in neuropathy should always be considered in patients on metformin. And remember, many of these things are clinically evaluated possible, with vasomotor dysfunction being one such example. Thank you very much for the patient audience.